where they are.
Does anybody like?
No, these other ones start with a dip. I'm not confusing them. Like I know one is connotation and one's refuge.
Okay, I'd like to talk just a little bit about spring and about externships. I think I have you pretty much set, and so far I've not had anybody tell me that it's impossible. Just a reminder, your externships are all day, 2 days a week. So most of you, it'll be Tuesday, Thursday. A couple of you, we're gonna have to make some changes because of the availability of the clinic. So, and you guys know who those of you are, and I haven't worked that out completely yet, but at least I know what your availability is now. So you all have access to the academic calendar, right? You know when semesters start and end? So you can always look that up if you wanna know, oh, what's the first day that we do this? We start right away. And the hours are whatever that clinic's office hours are. So they could be 9 to 5, they could be 8 to 6, they could be starting at 7 in the morning and done at 4 in the afternoon. So you just need to find out from that clinic what the office hours are for them. And you go whenever they have office hours, that's what you do. I got a nice email from Emma. You guys have been going there, and she says, and I just want to share this with you, you're kind of all over the place. Some of you are ready to jump in and take advantage of the opportunity to get your hands on, and some of you are hanging back and not wanting to jump in because you're shy or you're nervous or whatever. This is the most nurturing environment you're going to be in of any externship ever anywhere. And I have the expectation and I'm urging you, take advantage of this. Get your hands dirty. In her clinic, you're never gonna have a supervisor who is more supportive than she is. And she made the comment that if you are this hang back about, you know, that your confidence level is so low, it's gonna show when you go to your externship, and it's not gonna be a good thing. So she made that comment to me. I didn't even ask her about it. Now, she loves you, she loves having you, but she wants you to, at this point, halfway through the semester before you start your externship, she wants you to say, hey, can I do this? Can I do this hearing test? Can I do this, you know, whatever it is that you have the opportunity to do? And not hang back and say, oh, I'm not ready to do this. Because you need to be ready to do this. And after 3 semesters in clinic here, you should be ready to do these things. So is there anything particular that we need to talk about that you feel unconfident about, that we need to practice more, or that you need to practice more? Yeah.
It's not necessarily about like any like masking techniques or anything like that, but I just don't feel confident only doing the test on like a keyboard. I haven't been able to try that quite yet.
Okay.
And I don't really know how to do it on our keyboard.
I think you can just do it on our keyboard. Have you tried it?
Yeah, but like, what do I?
usually, arrow keys, up, down, and typing in numbers.
And there's 8 is to engage masking, and then it's page up and page down for the level.
Yeah.
You can technically use the mouse, excuse me.
Yeah.
But obviously that takes longer. But for sure, for your stimulus, like your tone, it'd be your arrows, and then I believe spacebar, and then enter was to sort it.
There's also a lot of shortcuts, like if you click 8, that's masking. If you click 9, that goes to speech. If you click R, L, right, left, it just automatically just goes to that.
So help each other.
Okay.
Maybe get together with each other and say, okay, let's go in and practice doing this on the keyboard, so that you can do it when you need to. And it's not the same keyboard, I know, but you know, that is another thing that you're gonna run into, is equipment that you're not familiar with. And you probably need to go in early and practice on it, or do it during your lunch hour, or whatever it is you need to do during your externship. I will tell you that when I was at House in USC, if I had a student come in and I would say, if you want to be behind the audiometer and test a kid, I need to see that you've gone in and practiced your, you know, to make sure that you can, you know how complicated it is to just do VRA and push the button and operate the audiometer and push it at the right time and everything. If you don't practice that, I'm not putting you behind the audiometer. And I can count on less than one hand in 40 years that I actually saw a student go in there at noon and actually practice. And I put those students behind the audiometer. The others were relegated to being a test assistant the whole semester they were there because they never showed me they could do it. So that's one of the things that I want you to be assertive about is, how do I learn to do this? I have a minute here, I'm gonna go in and practice. I'm gonna come in early and practice. I'm gonna do this during my lunch hour and practice. And when you show your preceptors that that's what you're willing to do, they're more than happy to help you. Okay? Does that make sense? Okay. So I just wanted to share that with you so that you know that her expectation is that you won't be shy. And I sent you over there initially to say, I think all you're gonna be able to do is observe. Well, happily, that's not true. So the fact that she has, basically pushed you in the deep end is a very good thing. Okay? All right.
I think you had a question.
Oh, I'm sorry.
No, I mean, it kind of comes on, like, it falls on like the responsibility of ourselves too, to just come in with practicing hearing aid fittings and then also setting an initial fitting, and then next time I come in, practice with adjustments and doing that. But I obviously, like, you could only do so much with, you could familiarize yourself with navigating through the different softwares, but then making adjustments according to like an actual patient for what their concerns are, that's a lot different.
Well, that's practice. That's experience.
Mhm.
You're gonna get that. That's why you have externships,
Mhm.
is so that you learn how to do that with real patients. And you will.
Yes.
And you will learn how to do that. What we did yesterday, because we had two students that were scheduled at 11 o'clock at the same time, and they called at like 11:15 to say, oh, we can't come because we have class.
Yeah, yeah.
I asked her twice. I was like, what? She's like, yeah, we have a class. I'm like, okay.
So anyway, we did all hearing aids on Tuesday. I think we had one patient in the afternoon, but we did a lot of hearing aids. And what you'll find in all of the software in one place or another is some really good tips on, the patient has this complaint, what do I do? It's different in different softwares, so you just need to become familiar with the softwares, and you will do that over time. And it'll say, they say it's too loud. Okay, what's too loud? Then it'll give you 10 different scenarios. Okay, if it's too loud here, here's what you can try. If it's too loud here, here's what you can try. If the other complaint is it's too tinny, or it's too boomy, or it's too whatever, they give you a whole list, and then you can click on that, and it will give you some ideas. Does that solve it 100%? No, but it gives you a direction to go so that you're not feeling like, I don't know what to do here. It gives you some things to try. And then they can tell, it's a little bit like getting your eyes checked. No, that made it worse, okay? Or that made it better, but it's still not there yet. And those kinds of things in the software can really help you. In addition to the experience you're gonna get. You're gonna learn that when somebody says it's too boomy, it's not a high frequency problem. If they say it's too tinny, it's not a low frequency problem, except insofar as if it's too tinny, maybe you need more low frequencies to kind of richen it up. So again, that's another reason that I send you to Emma's, because you get to see some hearing aid fittings there. You don't get it every week and you don't get it every time, but some of you will have that experience. And some of you will have more hearing aid experience than others initially, because Kaiser doesn't do hearing aids. So if I put you at Kaiser, you're not gonna get any hearing aid experience, but boy, you're gonna get a ton of other stuff. And then the next time I'll put you in hearing aid practice where you can get that experience, because you have 4 semesters where you can do this. Okay? All right, any other questions about externships? Okay, get ready. I know, cool, huh? All right, let's see. So, we're gonna see how far we can get with, that's not what we're gonna talk about. We're gonna see how far we can get on auditory neuropathy. Okay, so there's a lot of reading, and I do want you to do all the reading, so I'm just gonna make it a point to tell you that that's important. So auditory neuropathy, or really what it's called now is ANSD, or auditory neuropathy spectrum disorder. I don't love that term with parents, because when parents hear spectrum, what do they think of? Autism. It is a spectrum, there's no question that ANSD is a spectrum, but I prefer to just talk about auditory neuropathy with parents so they don't get confused about what condition you're trying to tell them about. It was first identified in the 1990s when OAEs became a clinical tool. We really did not even know about auditory neuropathy as a condition before that, because we didn't have a way to separate sensory from neural. So OAEs, that's exactly what they do. They separate sensory from neural. And they're looking at the outer hair cell function of the cochlea versus the things that go on beyond that, the more central functions. So sensory loss is a result of abnormal hair cell function, right? We know that. So they could be missing, they could be absent, they could be not transmitting within the cochlea properly. We could have malformations, so we can have no cochlea, we can have a malformed cochlea, we can have various malformations, from mild malformations to severe malformations. That's all cochlear. Neural loss is going to be a result either of the transmission from the cochlea to the eighth nerve, or it's going to be something higher up. And in our adult patients, that usually means they have an acoustic tumor of some sort, or a tumor that presses on some aspect of the auditory system. With children, that's much less likely. It doesn't mean that a child can't have a brain tumor, they certainly can, but they don't typically have acoustic tumors. They don't typically have meningiomas that lean against the auditory nerve. So when children have neural loss, it's usually what we call auditory neuropathy. It is so called because even though we don't know that most cases are actually a neuropathy having to do with the nerve itself, it's the term that most people know. That's the term that was given back in 1990 something. And it does, if we talk about it as ANSD, as we talk about it as a spectrum disorder, it accounts for different causes of the disorder that looks the same on an audiogram, but it isn't from the same cause. It also accounts for different manifestations of the disorder, because everybody with auditory neuropathy doesn't have the same audiogram. They don't have the same presentation. So ANSD is the most recent sort of official term for auditory neuropathy, which is still really poorly understood. We don't have tests for all the different, to say, oh, this is what part of the auditory system is not working well. We don't have tests that can tell us that. We've learned some things, but we still don't know. Sorry, hold on. Okay, so on the audiogram, what does it look like? It appears to be a sensory neural loss, but OAEs tell us they have normal or near normal cochlear function, at least for the outer hair cells. And so audiometric thresholds, which we usually think of as that's a peripheral hearing loss, right? It's either conductive or it's sensory, because most sensory neural hearing loss is sensory, or it's mixed. In this case, the responses that we get on an audiogram don't necessarily represent peripheral hearing. They can represent more central hearing. So physiologically, what's going on with auditory neuropathy is that it's thought to be a disorder of temporal coding, so a timing problem. It impacts the ability to process changing information, and of course speech is changing information all the time, isn't it? Speech is not one sound. Speech is a lot of sounds with a lot of different timing cues and a lot of different pitch cues and there's just a lot of stuff going on in speech. So the exact mechanisms and functions are still not exactly well understood, but they do know that the site of lesion may be presynaptic or postsynaptic. In other words, it can be a problem of the transmission of the inner hair cells to the auditory nerve, or it can be a problem with the auditory nerve not firing synchronously itself. So the inner hair cells are fine, they're transmitting fine, but the auditory nerve is not functioning properly. And it can be either one of these things. So functionally, what do we see? Well, classically, what we think of with auditory neuropathy is inconsistent responses to sound. That's not always true, by the way. Some kids with auditory neuropathy are very consistent on how they present in booth, how the audiogram looks. But in other cases, we have what I used to call Swiss cheese hearing, which is like one day they seem to hear pretty well and the next day they don't. And literally in the booth, can be difficult to test because it's like, the information is not getting through in a way that allows them to respond consistently. So some of our audiograms are pretty goofy looking. Sometimes it's progressive. So it may start out not so severe and become more severe over time. Sometimes it's associated with other neuropathies, with a diagnosis of something that is a peripheral neuropathy or a central neuropathy, or it can be associated with cerebral palsy. That's not an uncommon manifestation of auditory neuropathy. And behavioral thresholds don't correlate with other test results. So while I've been talking all this time about putting puzzle pieces together, with auditory neuropathy, the fact that puzzle pieces don't go together is one of the ways that we diagnose this particular condition. Because OAEs are an outer hair cell function, they are most often present in auditory neuropathy because the dysfunction is farther up the auditory pathway. So what we see from OAEs is they're present, they're robust, because that part of the cochlea is working just fine. But they're not functioning normally auditorily because they have a problem that's more central, farther up the pathway. At least at first we see OAEs in most cases. Sometimes they disappear, and we'll come back and talk about that later. But the presence of OAEs with auditory neuropathy, when it classically presents, has nothing to do with the degree of hearing loss that you get in the booth. They can have a profound hearing loss in the booth and still have present OAEs. So putting that together with, oh, what am I seeing here? I'm seeing a kid that's not responding in the booth, but they have beautiful OAEs. That should raise a high index of suspicion for you that you need to do additional testing. OAEs may disappear over time. We don't know why that is. We used to think it was because we were putting hearing aids on kids and like blowing out their outer hair cells, but even if we don't put hearing aids on them, sometimes OAEs disappear, and we don't know why. But initial infant testing, though, usually shows in auditory neuropathy big, robust OAEs. There's not even a question about whether they're present. They're usually huge when they're present. And that's not consistent with other results that we're seeing. So, present OAEs in isolation, then, could miss auditory neuropathy, right? Because typically we do OAEs in kids and we go, oh, the likelihood of them having significant hearing loss is pretty remote. If we have robust OAEs, it isn't usually even that they could have a 30 dB hearing loss, it's usually their hearing is fine. And that's a wonderful test for us, isn't it, that we can do that when we can't get good behavioral results. But if we look at it in conjunction with ABR, what we typically see is absent ABR. Well, that's not consistent with present OAEs, is it? So the initial hallmark of auditory neuropathy was and continues to be absent ABR, present OAEs. We might see extremely poor morphology on the ABR. So it's just kind of a mess. And maybe there's a wave 5 there, but it doesn't really line up very well. I will tell you that in my experience, I've never seen an ABR with a child that has a diagnosis of auditory neuropathy where I could identify a wave 5. Just not, typically just not there, bless you. Sometimes we will see, and this is probably a different kind of auditory neuropathy, where we might see early waves, like a 1 by itself and nothing else, and present OAEs. That's less common. And we may also see a cochlear microphonic. You know what a cochlear microphonic is?
We've heard of it, we haven't gone over it.
Okay, I'll show you what it is. Okay, so cochlear microphonic is an early wave representing the activity of the outer hair cells. So it's present in a normal ABR, it's present for all of us, but it's usually not visible because you have such a strong neural response for your later waves that it kind of gobbles up the cochlear microphonic. But it's easy to see when there's no neural response. So you've got no wave 1, 3, 5, but you've got this response at the very beginning. And if the baby is quiet enough, very often you can see a cochlear microphonic in a child that has auditory neuropathy. So if it's present, it occurs only at the beginning of the tracing. It doesn't ring out far. It's not a neural response. It is a response of the outer hair cells of the cochlea right at the beginning of the tracing.
What does it look like?
I'm gonna show you.
Oh,
I'm
okay.
gonna show you. Okay, we have to use insert earphones to determine for certain whether it's a cochlear microphonic, because with insert earphones, you can separate the transducer from the response. And I'll show you why that's important. With an insert earphone, the transducer is remote from the earphone, and so we can separate the acoustic stimulus that's delivered from the electrical activity of the transducer. So it separates the stimulus artifact. We can tell what's an artifact and what is actually a cochlear microphonic. If we use a circumaural headphone, the stimulus artifact and the cochlear microphonic would be simultaneous and indistinguishable. So you have to use inserts. Cochlear microphonics are the reason to do a click stimulus. So you don't have to do a click stimulus in a child that has beautiful responses on your tone bursts, because that's a neural response. You know the neural response is there. But if you're getting a no response ABR, if you start out with tone bursts and you start out with 1,000 hertz tone burst or a 2,000 hertz tone burst and you get no response, you do want to do a click, because the click is going to be what tells you, is there a cochlear microphonic present? The cochlear microphonic is present at high levels, so like around 80 dB NHL to a click stimulus. How you control for the stimulus artifact is that you pinch the tube. So remember, you've got your little thing here and you've got the tube that goes up to the insert. Pinch the tube and do a no stimulus run. So they can't hear it because you pinched the tube. It's not this, the acoustic stimulus is not getting there, but the stimulus artifact is coming from the transducer itself. And so you'll still get that response. If you pinch the tube and you still get that response, that's an artifact. If you pinch the tube and that wave goes away, that's the cochlear microphonic that disappeared, okay? So a true microphonic will flip over when you change the stimulus polarity. Remember that you can do rarefaction, you can do condensation, or you can do an alternating click. Those are the choices that you have in ABR. If you do rarefaction and then you do condensation, the wave that you see will flip over. It'll become a mirror image. So here's what that looks like. So you run a condensation, and at the very beginning of the tracing along the timeline, you see this little wave. And then you run it again with a rarefaction, flips over, and when you superimpose them, look what you get. You get this beautiful little mirror image of those two waves, okay? True neural responses don't flip over. This is the cochlear microphone. So what it looks like for real is that. So you can see that there's no neural response there. There are no waves 1, 3, 5 there at all. That's just a bunch of junk, right? There's nothing that you can identify as a wave 5. But at the very beginning of the timeline, what you see is a bunch of waves. And that's run with a rarefaction click, and then you run it again with a condensation click, and you put the two together, and that's what it looks like.
So this shows us that the cochlea is
The outer cells, outer hair cells of the cochlea are functioning, or you wouldn't be able to see that.
most likely in the nerve.
Right.
Rules it out.
Because if the cochlea is operating nicely, if your outer hair cells are functioning, you should get ABR waves, shouldn't you? Oh, you're not getting any, okay? And if it was because they were cochlearly deaf, you would not get a cochlear microphonic because their cochlea isn't functioning, right? So this is an indication that outer hair cells are functioning, but up the brainstem, not happening.
So if it was normal, you would see just the normal ABR response?
Yeah.
Okay.
And you wouldn't see that cochlear microphonic in a normal ABR response because your neural response is so big and the cochlear microphonic is a small response. So here's what it looks like if you separate them. You run a rarefaction click, you run a condensating click or condensing click. See how it flips over? Now, if you ran an alternating clip, you wouldn't be able to see the cochlear microphone, right? Because they would cancel each other out. So you're not seeing it there. Same thing with the left ear. So when you are going to do your ABR testing for the purpose of finding a cochlear microphonic, you have to run a rarefaction and a condensation clip. Are you, in your ABR, what kind of a stimulus are you using? You're using alternating now. So you're not gonna see a cochlear microphonic with an alternating clip. You're gonna have to run rarefaction and condensation.
And you just do like once at 1,000 and you just see.
You do it to a clip.
It's like.
And
Yeah.
we don't, since it's at the very, very beginning, do we need to run as many repetition rates and samples, or?
Well, you wanna run enough that you see it.
Mhm.
So you wanna run the usual number of runs that you would run.
Okay,
Yeah.
okay.
That was a good sentence, wasn't it? Run the usual number of runs that you would run. You get what I mean.
Makes sense, yeah.
Okay. All right. So, what are the risk factors for a child having auditory neuropathy? We do know that there are specific genes, right? You studied some of that in genetics, that there are certain genes that are known to produce hearing problems, and those are specifically auditory neuropathy. What's an example of that?
DNFB like 59 or something.
59, I think is what it is. Yeah, it's very rare, that gene, as far as we know. That isn't like spread across a huge population. But abnormality of the otofurlin gene is another one. So we suspect that that accounts for the cases where we see several children in a family that have that don't necessarily have that DFN59, but they have an abnormality of the otofurlin gene. They don't have anything else going on with their development. They're otherwise developing typically. They didn't have traumatic birth, they didn't have any of that other stuff. They just got a genetic thing that produces auditory neuropathy. And that is suspected to be the cause, or the function of that is presynaptic, that it is the inner hair cells that are not able to transmit effectively to the auditory nerve. Some of our children have other peripheral neuropathies. Charcot-Marie-Tooth is one of them. Friedreich's ataxia is another one of them. There are several of these kinds of things that affect other systems. That I had a cochlear implant patient who seemed to be pretty typically developing when he was a little guy. He got him cochlear implants, and over time, his vision started to go out, his coordination started to go out. He's now deafblind. We were never able to find out if he had auditory neuropathy per se, because he was implanted before we even thought to do this, because he seemed to be a typically developing kid. But over time, he sort of began to deteriorate in all of these neurological kinds of ways. And the way we first discovered that he had something else going on is when he was about 3.5, and we were showing pictures to him, to point to pictures, and he would pick up the pictures and look at them like this. And we said, oh, he needs to get his vision tested. And so just kind of one by one systems started to break down for him. But one of the most common ones that you will see is children who have super high bilirubin, especially if they have to have an exchange transfusion. So when you take your history and they say, yes, they were in the NICU and their bilirubin was really high, or they were really jaundiced and they had to actually have blood transfusions, that's a huge old red flag for auditory neuropathy. So you want to be aware of that, and you want to check that out with whatever testing is appropriate as soon as you possibly can, so you know what you're dealing with. And because high bilirubin is more common in NICU babies, that's the reason that when we do newborn screening, babies in the NICU get ABR. They don't get screened with only OAEs, because OAEs can miss auditory neuropathy. So ABR is going to show you, oh, there's no response on the ABR. Maybe you'll be able to see, when you do the diagnostic, you can do the cochlear microphonic, but just in a screening, you're going to get a no response ABR in your screening, and then that will cause a referral. Whereas if all you did was OAEs and they passed the OAEs, it would be, hey, everything's fine, and everything is not fine.
So what is it about the exchange transfusion that makes it higher
I think it's not the exchange transfusion that makes them higher risk, it's the fact that they need an exchange
And
transfusion.
it was that bad?
Yeah.
Okay.
So, okay, so we get a baby that didn't pass newborn screening, and we do an absent ABR. If all we have is an absent ABR, what do we think?
Profound.
We think they're deaf, right? Yeah, we think they have a profound hearing loss. Oh, but then we run a click and we see they have a cochlear microphonic. Now what do you think?
ANSD.
Yeah, and we have to make sure we pinch the tube, make sure that we're not looking at an artifact, a stimulus artifact. And then we also need to do OEEs, because we need more than one test. We need to actually look at a whole battery of tests for every baby, so we're gonna do the rest of the testing that we would normally do. And they have present OEEs. Oh, that's another check the box, right? They have cochlear microphonic and they have present OEEs, but they have an absent ABR. There really is no other condition that you would say, oh, maybe they have no, that's pretty much it. But there is one more, and that is that they have absent acoustic reflexes. I've seen babies that don't have OEEs. I've seen babies where we can't get a cochlear microphonic, but we do have OEEs. I have never seen a child with a diagnosis of auditory neuropathy that had acoustic reflexes. So that's the fourth piece of information that you're gonna look at. Typically normal temps, absent acoustic reflexes. What do we know about hearing from this? Nothing. We know nothing about their actual hearing. So the test results appear, yes?
Sorry, you said they would have normal temps but absent errors.
Because if they didn't have normal hearing, normal temps, then you wouldn't know why their acoustic reflexes are absent. But if temps are normal and acoustic reflexes are absent, that's another piece of information that you put together.
Their OEs can be present, but are they always present?
They are not. So you have to rely on other things. So if you have, for example, so the ABR is always abnormal. If you have an abnormal ABR, well, that could mean they have a peripheral hearing loss, right? It could be a kid with a sensory loss if you have an abnormal ABR. But you have a cochlear microphonic. Okay, that's not typical. I mean, cochlear microphonic means the cochlea is functioning, at least from the outer hair cells. You do OEEs, OEEs are absent. Well, you still have that cochlear microphonic that is typical of auditory neuropathy. You go ahead and do temps and reflexes are absent. Well, reflexes could be absent if the child has a severe hearing loss, but you have that cochlear microphonic, okay? So putting the picture together is like, this is a kid with auditory neuropathy. Or, conversely, you do the ABR, there's no response on the ABR, but you really can't get that cochlear microphonic. It's too noisy, baby snoring, it's just, the waves are, you've got electrical interference in the room, which happens sometimes, and you just can't really say for sure that that's a cochlear microphonic. But you have robust OEEs. Oh, okay, absent ABR, present OEEs, right there. That's the diagnosis of auditory neuropathy.
I have one question.
Yeah.
So when we're measuring for a cochlear microphonics, what's the stimulus intensity?
80.
Okay.
Yeah, it should be present at 80. Yeah.
Is this something that we're diagnosing, or we get those test results and then we refer?
No, you do it.
Okay.
Yeah, you do it. The same way you diagnose a sensory neural hearing loss or a conductive hearing loss. You're not going to diagnose Friedreich's ataxia.
Mm-hmm.
You're not going to diagnose the condition behind it or that they have an abnormal otoferlin gene, but
just
you
that
are
there's-
absolutely going to be the one that says this is somebody who has auditory neuropathy.
Are we the only ones to diagnose this kind of like APD?
Yeah.
Okay.
The neurologist is going to, if you send them to a neurologist to look at their overall functioning, or you send them to a geneticist, they're going to say, yes, we found a gene that's consistent with that, or the neurologist is going to say, yes, we have other, issues going on, but they're coming to that person that you're referring them to with the diagnosis of auditory neuropathy, the same as you're gonna send them to a physician with a diagnosis of sensory neural hearing loss or conductive hearing loss.
So I'm probably jumping ahead here, but for kids, we have to refer to ENT for medical clearance anyways. Is there anyone else we have to refer to technically?
No.
Okay.
Now, probably the right thing to do would be for the otologist to say, let's look at other systems, you know, that are going on here. But your job is to send them to an otolaryngologist or an otologist.
Another thing, and this is just like kind of drilling it in for me. So the child may be able to hear, but it's also going to be inconsistently. Like there might be times where
We're
there's,
getting
okay.
So, these test results appear inconsistent, and they are inconsistent for the vast majority of children that we see who, if they have sensory neural hearing loss, actually have sensory loss, or conductive loss, or mixed loss. But in fact, they do tell us about what's going on. It just doesn't tell us what they hear, okay? Because children with auditory neuropathy can hear pretty well, or they can hear poorly sometimes and better other times, or they can be functionally deaf. They can have mild looking thresholds, but have very poor word recognition, very poor speech perception, very poor speech and language development, even though they have pretty good looking audiograms, or they can have much better speech perception. We don't know all the things that are going on to explain why children function differently with this diagnosis.
Earlier when we talked about the AVR though, and you said, abnormal AVR, is that just inconsistent with the OAEs and all of that, or could it be like latency differences, or
Now, you're usually not even gonna see a response.
you just won't see them?
I mean, the literature will tell you that the morphology could be extremely poor. I'm just telling you that the majority of children who have this diagnosis do not have an AVR response. I'll show you a couple of exceptions to that, but
And that's why you're able to see the cochlear microphone?
Yeah.
Okay.
because there is no neural response. So, we have to do behavioral on these children. And that includes trying to even put little bitties in the booth and do BOA, just to see if we can get some kind of response from them. No response is kind of no information, but when we do get a response, at least we have an idea of, oh, they're not functionally deaf. They're not, there's not no they're there. There's some kind of response that we can see. We can wake them up from sleep, or we can keep them from, like if they're a little bit fussy, we can interrupt that fussiness. You know, we can get some sense of what's going on. There is no physiologic test that we know how to do that will tell us what a baby with ANSD hears. ASSR is basically the same neural generators as an AVR. So you're not gonna get an ASSR response either if you don't get an AVR response, at least not with the technology that we have currently. So behavioral testing assumes varying degrees of diagnostic importance at different ages, and we know that, right? So in a child that has an AVR response, we're probably going to operate off that AVR response in fitting hearing aids because it correlates very nicely with their behavioral thresholds. That is not the case here. So we have to get some behavioral information. So AVR, OAEs, TIMPs, acoustic reflexes, those tests that we do identify the condition. They do not tell us what the child can respond to, okay? So the same physiologic test results can be present with children that respond in all different ways. So you can't decide ahead of time. They have auditory neuropathy, therefore, the way we can with AVR typically, because it can pretty much look like anything. Sometimes the configurations are kind of weird. Sometimes they're reverse slope, sometimes they're jagged, sometimes they're flat, sometimes there's no response. So they can look like a lot of different things. So degree of hearing loss, and it's still gonna be, in everything that you read, it's still gonna be described the same way as you would typically describe an audiogram. But I think really, just so you know, these are better described as minimal response levels. What they're able to respond to today in the booth. It's not really correct to describe it in the typical terms that we use, the or mild to profound or sensory neural hearing loss. It's not really, because it implies a peripheral hearing loss, and it's not what's going on here. These are neural losses, they're not sensory losses. It might be more accurate, but it's not conventional to say that they respond at a mild to moderate level. That would actually describe it better, because that's how they're responding today, more so than they have a mild to moderate sensory neural hearing loss. Because tomorrow it could be a little bit different, or it could be the same every time you test them. So it's variable. So what are the classic results? Classic is absent ABR, present OAEs, present cochlear microphonic, absent acoustic reflexes, very poor speech discrimination or word recognition or speech perception. Okay? That's the classic. But often not all those signs are present. So that's why we have to do everything, and we have to draw a conclusion from the results that we get. So we could have absent ABR, absent acoustic reflexes, present cochlear microphonic, but absent OAEs. And we don't know why that is. Or we can have present OAEs, but no clear cochlear microphonic. If you suspect a child has auditory neuropathy from their history, so they had high bilirubin and they had an exchange transfusion, and you have a high suspicion that this is what it's going to be, and you get an absent ABR, but you don't get a cochlear microphonic, and you don't get OAEs, suspect as you like, you can't make that diagnosis. You have nothing to distinguish it from child has cochlear deafness. Okay. You could still keep a really close eye on that kid and do behavioral testing and make sure that they're getting all of the therapy that they need, and you're watching their progress. And it may be later that you might want to repeat one or more of those tests to see if something more definitive pops up. But you can't say it without the test results to back it up. Sometimes OAEs disappear with time, as I mentioned, so even without hearing aid use, so they might not be present in a child who isn't diagnosed until they're 2 or 3 years old, because maybe they had robust OAEs when they were born, maybe they passed newborn screening, but by the time you see them at 2 or 3, those OAEs are gone. And that can be pretty tricky, because suppose they didn't have any risk factors and they passed newborn screening, because newborn screening was done with OAEs. And as they're getting older, they're 2 years old, they're not talking, and they're 3 years old and they're not talking, and then when somebody says, hey, we better do a hearing test, and you get kind of weird results on the hearing test, so you do OAEs again, and the OAEs are absent. Well, now there's a problem, okay? Now you know you have a problem. Maybe you're gonna wanna do an ABR, and oh, the kid is responding at 40 to 50 dB in the booth, but they've got a no response ABR. That doesn't make sense, does it? And they have no OAEs, but maybe they have a cochlear microphonic. Or maybe just the inconsistency between an absent ABR and responding in the booth at 40 or 50, that doesn't make sense either, does it? So again, now your index of suspicion is very high, even if you can't prove it.
So if you have a kid like that who's 2 to 3 and they're responding at those moderate levels in the booth, but ABR is absent, for hearing aid programming, are you going off just what's more consistent
Yes.
from them? And then using like their feedback of like, oh,
Yep.
it might be too loud?
Yep.
Okay.
And kids with ANSD usually don't complain that things are too loud, because they don't have recruitment, right? That's usually a cochlear phenomenon, is things are too loud. The diagnosis, though, does not change our immediate action. It doesn't really change what we do at first, because what are we gonna do at first when a kid has a hearing loss?
Hearing aids.
Hearing aids. So later on, we may decide that they are better served with cochlear implants, but we're always gonna start with hearing aids.
For ANSD, do they typically have like intact cochleas, or is it like common to have like Maldini malformations? Okay.
No, it's a neural problem, not a cochlear problem.
Okay, cause sorry.
No, go ahead.
Cause I just remember, like briefly when we had talked, not us, a different professor, talked about, this, is that sometimes they can be a CI candidate, sometimes they can't, so I was like wondering if it had to do,
Who could be a cochlear?
ANSD
Oh,
sometimes.
yeah, that's usually gonna be the recommendation if they're not benefiting from hearing aids.
Yeah, but like, what would be, like, the reason why they wouldn't be?
I don't know,
Oh,
if they had, I don't know. I mean, that would be the direction that we would go,
okay.
yes.
So we start them off with hearing aids, but they usually have poor speech recognition, and as children, wouldn't we want them to get cochlear implants first or right away?
We don't ever do cochlear implants first, ever, not
So
any,
how
on anybody.
far between fitting them with hearing aids and then deciding on?
We'll talk much more about this when we get to the implants class, but you put hearing aids on and you get them in whatever kind of therapy you can get them in, and you look to see what their progress is, and if they're, then we're gonna look at cochlear implants sooner rather than later.
So what's like, how much time are we giving them?
3 to 6 months.
How
Yes.
successful are they with cochlear implants though? If it's
They
another-
They are. It's kinda weird, isn't it? We don't know why, I'll get there, but yes, they are.
So you're a little guy who had the vision problems that were progressive. Did you notice that his performance with the cochlear implant also declined?
No.
Okay, so even if it's like a progressive ANSD,
He was never a superstar with his cochlear implants, but definitely a spoken language user, absolutely. He had some difficulties with programming, and I don't know why this is. He was a kid that always wanted it to be louder, but when we made it louder, he had facial stim. And it was really, we tried everything we could to give him the volume that he wanted without giving him facial stim, and it was not possible. So, we made the best compromise that we could. So definitely a spoken language user. But, continued to progress auditorily and in his speech and language.
I have a question.
Yeah.
So you said if you fit the child with hearing aids and then they're not making progress in speech therapy, if they have other complications going on that could be impacting their progress, how would you kind of rule that out and make sure that, am I explaining myself?
That's why we're a team.
Okay.
In other words, if they have access to auditory information, but they're not using it well, then we would consider a cochlear implant. If it's a child that has additional reasons why they might have a speech and language delay, we have to figure out how much do we think that the auditory problem is contributing to that, and if we think we can make it better by giving them a more direct route through the auditory nerve than going through outer hair cells, or perhaps the cochlear implant synchronizes the activity of the auditory nerve better. Let's do it.
Or I think my question was, how would you confirm or rule out that maybe the hearing aids are not helping the child?
In the way that we always confirm or refute the fact that hearing aids are helping. Are we matching targets? Have we fit them appropriately and they're still not progressing in the way that we would think? Let's do something else. Yep. Okay. So we have some sort of cross diagnoses to consider. So auditory neuropathy or cochlear nerve deficiency. Is it that we actually have a transmission issue or a synchrony issue, either of which could be classic auditory neuropathy? Or is the nerve itself not fully functioning because it's thin or it's deteriorating? It refers to a nerve that is present but small, or it may not be, you can't, when you're looking at the internal auditory canal and you see those 4 nerves coming through there, you can't really tell which nerve is which. It's kind of hard, and you know where they're supposed to be, but sometimes anatomy is off and you can't quite figure out what's going on. So we do CTs and MRIs, mainly MRI, to show that. And we're learning that maybe there's a contraindication to doing a cochlear implant because we don't think that the nerve is there, or we don't think the nerve is functional enough. And some clinics will do electrical stimulation on the promontory to see if they can get some response from the auditory nerve to determine whether they're candidates or not. There are some proposals to try to narrow down the definition of auditory neuropathy. whether we're talking about transmission from inner hair cells to the auditory nerve, or we're talking about the synchronous function of the auditory nerve itself. But we don't have any tests at this time to really delineate. So we can do genetic testing, and if that's positive, then we have a reason to think, oh, this is a presynaptic problem because it's an otofurlin gene, or it's some other gene that we know is associated with auditory neuropathy. But if that genetic testing doesn't come up positive, we still don't know. We still don't necessarily know the difference. If it runs in families, it's more likely to be genetic. If it's a child that had a traumatic birth history or they had high bilirubin, it's more likely to be something that is acquired rather than genetic. But we're just kind of guessing about this. We just don't know that much about it.
Going back to the last slide for CND, is that like a condition on its own, like ANSD, or is that like a symptom of like another condition?
I think that's variable.
Okay.
I think that there are some people that have skinny little auditory nerves and they have hearing loss as a result of it. And sometimes they have progressive hearing loss because it's deteriorating. There could be an underlying condition to that. Sometimes we see that in just their overall development. Sometimes we don't. Sometimes they are developing typically, but that seems to be the cause of their hearing loss when we do imaging. Okay, so now what? Get going on hearing aid fittings with the information that we have, or do we wait for reliable behavioral? Because remember, when we do behavioral observation, it's not threshold information. So how do we fit hearing aids? And not all clinics agree on how to proceed with this. So for example, we always put hearing aids on them right away. And we put them on based on what we could see in the booth and conservative programming until we could see how they responded with it. If it appeared to be too loud, then we backed off. If it appeared they were doing nothing, then we increased the power to see if we could get a response. Initially, we never put hearing aids on our kids that were identified with auditory neuropathy. And I remember the first time kind of the light bulb went on for us. It was a kiddo that came from Australia actually to house. And they said, you know what? Yes, he has auditory neuropathy, and I know that the way that this is typically done is that hearing aids aren't even recommended. But we decided we were gonna do everything we could, so we persuaded the audiologist to put hearing aids on, and we persuaded the audiologist to fit with however he seemed to be responding, which is he wasn't responding. So they put hearing aids on him, and they cranked up the power, and he responded. They got actually some benefit, not a ton of benefit. He ended up getting a cochlear implant, but to start out, it was like, ooh, we want to be very careful we don't blow out those outer hair cells. Because they're using them? No, because they're not, you know what I mean? It's like, yes, they had function of the cochlea, but they weren't able to do anything with it. And so we started fitting hearing aids, starting conservatively, turning up the power as we were seeing what kind of responses we were getting. So we can repeat the ABR to confirm the diagnosis, but it doesn't do any good in terms of helping us know what they can hear. So behavioral testing, we just have to continue. We have to start it earlier. We have to continue to do it. UCLA never put hearing aids on kids until they could get good behavioral thresholds. We did the opposite. So there's no single way to do it. We just felt like they have this diagnosis. We know something is wrong. We don't want to waste the first 6 or 7 months of their life with no sound, you know, potentially no sound getting in there. We want to at least do some experimenting, which is what we did way back when, before we had good ways of testing babies, is if we thought they had a hearing loss because they weren't responding in the booth, but they weren't really very reliable, we would put hearing aids on them and see what we saw, and turn them down or turn them up, depending on what their responses were. That was sort of meatball audiology, you know, before we had good testing. So our idea was basically get the baby on the air with whatever minimal information we had. But again, you may work in a clinic where they say, no, that would be a terrible thing, you can't do that. When in Rome, right? Okay, so I just had that conversation with you. All right. There is no way to predict what kind of hearing aid benefit we're gonna get. We have a reasonable expectation that a child who has a moderate cochlear hearing loss is gonna benefit from hearing aids, and they're gonna develop spoken language if they get the right support services. We really don't know that about kids with auditory neuropathy, because often their word recognition is so poor, their discrimination of speech is so poor, that hearing aids just making things louder don't solve the problem. They may get better benefit just from improving the signal-to-noise ratio with a Rogers system, for example, if they have reasonable access to sound. If they're responding at the bottom of the audiogram, of course, that's not going to help. But if they're responding at, so-so levels, and they just really need to have help distinguishing speech from noise, Rogers systems can be very helpful. Or they might do pretty well with hearing aids. So we need help from the community. We need help from parents, from teachers, from therapists. How are they doing? What are they doing? Are they making progress in therapy? Are they developing spoken language? Are they responding to speech at all? Are they responding to environmental sounds? Are they able to distinguish environmental sounds and distinguish different speech sounds? Or are you seeing anything negative? Are you seeing that they're startling or crying, which is unusual with a child with auditory neuropathy, but it can happen? Are they responding better than you expected with that diagnosis? We need this information to know how to proceed. If they are responding well with hearing aids, and we're seeing some actual responses, we're seeing some development of spoken language, they may still be slower in their progress than a child that has cochlear hearing loss, but they're still making forward motion. They might develop spoken language with hearing aids, but they may have more challenges with a child. They may have pretty good language, but their speech production is really poor, because maybe they're getting a corrupted signal that they've been able to make some pretty good sense of, but that's where the speaking what you hear comes in. But what they're hearing is not an intact signal, and so their speech production is poor. They may benefit from or require visual cues more than a child with cochlear hearing loss. Might be supplemented by either sign language or cued speech. You all know what cued speech is. Okay, cued speech is a system that isn't really, it's not a language system, but it is a supplementary system that helps with speech reading. Because speech reading in English, 30% of speech is visible on the lips. So when we talk about, they're a great speech reader, they can speech read everything on the football field and stuff, that's pretty difficult to do. So what cued speech does is it uses 8 different hand signals to enhance the movements that are visible, to show you that things that look the same on the face, now you have a hand signal that shows you it's this or it's that. It's not a big, hugely used thing on the West Coast. It's a much bigger deal on the East Coast. There was a group of cued speech people that was started by a parent who had a kid with a kind of hearing loss, that he just didn't do well with hearing aids because it was terrible hearing loss to try to fit, so they supplemented with cued speech. I had a cochlear implant patient that lived up in the Central Valley, which turned out to be a really good thing that they learned cued speech, because she had a cochlear implant device failure, and she had an infection, and she had to be off the air for 2 months, and she was able to get by with cued speech and speech reading with her family. So this can be really helpful for kids that have auditory neuropathy. Yes?
So if, like out here for cued speech, if you had a family who was interested in that for their kid, what's the likelihood of being able to find someone around here who knows how to?
You probably start online, and then if you were really wanted to do this, you'd pull together a group of people and say, let's do this. Yeah, I haven't looked for a long time to see what the resources are locally for cued speech. There probably still are families that use it. It's just not as commonly used as it is in other parts of the country.
So it wouldn't be something that like a parent could request in an IEP?
They could, absolutely, they could request it.
Okay.
Yeah, absolutely, they could request it.
It's just if it's
The question would be,
denied.
okay, how easy is it gonna be to find somebody to do that? And the IEP team, of course, would have to agree that that would be a good option for that child, and we're gonna find resources to help with that. IEP is a contract, right? It's an agreement between all the professionals in the school and the parents and the child. So sometimes parents ask for things that are not appropriate, and sometimes they ask for things that are appropriate and get turned down, so it's a discussion. Okay. If they're not responding well with hearing aids, regardless of the degree of hearing loss, in other words, regardless of what the audiogram looks like, and they're not developing auditory oral skills, they might be a CI candidate. So where we typically look at CI candidacy as being, anywhere from a mild to a profound loss, depending on what type of device you're gonna use. With children with auditory neuropathy, we might provide a cochlear implant or cochlear implants to a child that has what looks like quite a bit of residual hearing, much more than we would typically do, because they're not doing anything with it. They can't do anything with it. So let's try a different type of device. See if we can bypass whatever that non-functional part is. They may also end up being visual language users. So in other words, if they are not benefiting from hearing aids, and perhaps the family does not want to have a cochlear implant, or they don't live in an area where they have a surgeon that's willing to implant a child with moderate hearing loss or mild hearing loss, then maybe the best answer for them is going to be sign language. Language, language, language is the most important thing. So while we're all about hearing for the purpose of helping them develop language. If hearing isn't gonna do it, then we need to be sure that they're getting language through some other modality.
So do you find that it's, because there's so much variability on how they might perform with hearing aids or cochlear, that it's just safe to maybe recommend implementation of sign language since the beginning of the diagnosis?
Not necessarily. So it depends on what the parents want, the same as what you would do with a child who's deaf. In other words, we would say, these are options. This is one possibility when a child has a diagnosis of ANSD, that it's gonna be very difficult for them to make sense of what they hear, and you may want to implement visual language from the start, or they may say, oh no, not doing that. So that's a discussion. That's not you have this diagnosis, therefore we're recommending this.
It's just scary to think like if they wait longer and then they are past like the age of critical language acquisition, that then they might not acquire language fully.
We certainly would not wait till they're past the age of critical language acquisition before having a discussion about this is not working. Yeah, no, we're not waiting till they're 5. Okay, so for many children with auditory neuropathy, cochlear implants are very effective. Why they are is not exactly known. It might address temporal coding by, making the auditory nerve fire more synchronously. It might bypass that synapse that's not working in presynaptic causes of auditory neuropathy. And where they are candidates, typically bilateral implantation is recommended, given the most possible access to sound that we can. Rather, more children with auditory neuropathy probably end up relying on sign language than children that don't have it, but that's because I would say, in my experience at least, because there are children who have auditory neuropathy who have additional disabilities. So that the children with additional disabilities have slower progress with cochlear implants, whether it's auditory neuropathy or not. Children who have auditory neuropathy and no additional disabilities tend to be fantastic users, just like kids that don't have auditory neuropathy, if we do it soon enough and if they get the appropriate supports. So, that's time to go, sorry.
No.
But I can answer your question, but I was just gonna say, we'll do case examples next week, because I don't wanna jump into this. I'd rather have you do some reading, do some thinking about this, and then we'll come back and we'll talk about cases. But what was your question?
So do you typically recommend, because we said with bilingual, like language acquisition can even be delayed a little bit more to date, do you typically recommend that they're only learning one language then?
Don't do it, because what happens is then parents stop talking, and that's worse than talking in 2 languages or 3 languages. Yes?
I guess you recommend bilateral implantation. Have you seen cases where they might have like asymmetrical benefit, like one year is worse than the other, and one year benefits more than the other?
I think that's true for
all kids who have asymmetrical presentations, because we don't always know why that is. I'm trying to think of how many kids with auditory neuropathy that I've seen that have really asymmetrical losses where we might only implant one ear, for example. Not a lot. Not a lot. I mean, I have a case here of that very example, but he was a lousy candidate, and I'll show you why. But yeah, and again, you know, it's hard to say globally. Every kid needs to be evaluated individually to determine what's gonna be the best path for them. Heather, yes?
So, sorry, just going off her question, is it usually symmetrical for ASD patients?
I don't know if usually is the right word.
Okay, and then my actual question, so the reason we talked about CND is that because it's often confused with ASD?
Well, before we were doing MRI imaging where we were really looking at the state of the nerve, sometimes it looks like auditory neuropathy, yes. And sometimes sometimes it is auditory neuropathy. Again, it's a big, wide spectrum term. So we're looking at some of these kids that have a diagnosis of auditory neuropathy. Many of those kids, when you do an MRI, everything looks normal. But some of these kids have abnormal MRIs. So is it really auditory neuropathy in the way that we've been thinking about it, or is it because they have a physical, visible difference in their auditory nerve? Other questions?
Sorry, so usually when there is, the MRI shows a physical abnormality in the nerve, that means it's CND, not ASD. We never have that in ASD?
It could be both.
Okay.
It could be both. I mean, we're still trying to figure out what this is. And we're trying to figure out what all of the things that this is, if you know what I mean. So initially, the idea was auditory neuropathy was dysynchronous auditory nerve firing. And then we figured out about otoferlin and realized that that is a different cause completely. That's inner hair cell function transmitting to the auditory nerve. That's not a synchrony issue. So as we learn more, and now we're looking at, MRIs are showing that on some of these kids, they've got skinny little auditory nerves, we think. They've got something abnormal in that nerve bundle that's coming through the IAC. So, we don't know. We know it's not your typical cochlear hearing loss. And the kids that have it don't respond in the way that a typical kid with a typical cochlear hearing loss responds.
Is that where we see like the present OAEs? Because it's like it's not.
Outer ear cell function is fine.
Okay, yeah. That makes sense.
Outer ear cell function is fine. Okay? All right, go read.